Thank you. Thank you. I hope everyone can hear me. It's a pleasure to be invited. Thank you, Anne, for that lovely introduction. I was teasing Anne earlier today. Don't invite people so old because their bios go on and on and on. So it helps to have a shorter bio. And thank you to Dean Jing Wang for inviting me here. It's been a thrill to do this. I've been a dean for 10 and a half years now. I'm in my last year as dean. And so it's been fun to have a brief conversation this morning with the faculty here. And I look forward to your questions. And back at NYU, I'm known as Dean Eileen. So that's easier than Dean Sullivan-Marx and all of that. I could tell you a story of why that's hyphenated, but that's for another day. But having to do with my son and nosebleeds and daycare. So anyway, happy to be here. So we thought we would talk a little bit about lessons learned in the past number of years of, post-COVID. We're not really post-COVID. That's why Dean Wang is not here in person. Not that she has it, but just to be on the safe side. If anyone has a sniffle, you start to wonder. So we're a little, we're somewhat past it. We're at least past the crisis. And being in New York, we knew what the crisis meant and how it hit us. And so I'm going to reflect a little bit, and this gives me an opportunity to put my own thoughts together. You could have your own. I think it's a good idea for all of us at this point to take time to reflect over what we've been through personally, journal about it, but also from our own professional standpoints, whether you're a student or whether you're been a teacher for a long period of time. Thinking back and putting it together in some kind of framework was helpful for me, even in preparing this talk. So I have six lessons. So how did I even decide on what those lessons might be? And as I used reflection, I used stacks of evidence that I had been putting aside over the course of the last 3 or 4 years. It's like, oh, this is an important article to read, or I had them on a file. But of course, looking at what we've been through, it's enormous to have a metaphor, to have an understanding of what visually this looks like. And I think this particular recognition of people and personal lives that have been lost, but even larger than that, every one of us have experienced something related to COVID and how our lives were changed over this course of time. And what we decided to do at NYU in nursing, we are located on First Avenue, New York City, right at 26th Street, across the street from Bellevue Hospital, down the street from our own NYU Langone Health Medical Center, next to the city public health building, and across the street from the toxicology department and the city morgue. And to our right is the New York Hospital Veterans Administration Hospital. So that experience exposed our students and as well as our teachers. And I remember as we realized that things were going to turn around very fast in March of 2020, the student leadership came to the associate dean, came to me, and they were, raising questions, raising concerns. This is as the week rolled out, and we're, Monday by hour realizing patients and ambulances, sounds, and patients are coming into the ER. And so I said, let's meet with our students on the top floor, the 11th floor of our nursing school building, which had a conference room and a wide view of that part of the world across the street from Bellevue Hospital. And we took a moment to just reflect that we were across the street from the oldest hospital in the United States, where the first nursing school was founded at Bellevue Hospital, which is the center of public health in New York City, but really, if you think about it, in some ways around the United States and around the world. There's only a few hospitals that can handle these kinds of pandemics. And I said, students like yourselves, students before us have gone through these, whether it had been tuberculosis crises or whether it had been the Ebola a few years earlier, or in the past with cholera outbreaks, typhoid fever outbreaks. It all took place right across the street. And that your student generation will now be the leaders and the future who will carry this forward throughout your entire career. And we will get you through this, but you will understand that some of what you're going through is going to be very different and uncertain for you. And so one of the things that we did after, the initial crisis, so I would say post-vaccine 2021, we asked our alumni, our students, our faculty to create art throughout our building. And we would have an art installation that we now consider to be a permanent art installation called When the World Went Still. And this quilt represents, made by two of our alumni, the kind of experience we had in New York City. As you're looking at this on the far left of this quilt, and our colors are violet, if you can't figure that out already. So they did everything in the violet motif and rainbow colors and the sun coming up and the tall buildings in New York. But that's our nursing school building in purple. That's sort of the style of what the building looks like. But you can't see this, but some of the, when good quilt makers are crafty and they add three-dimensional things or little craft things on it, they put in, they found small paper bags and tied that in, and pots and pans that people bang together in New York City every night at 7 o'clock to recognize the work of the workers, and everyone would lean out windows and bag pots. So they put that on there. But what was the paper bag all about? People say, oh, was that carrying their lunch? No, if you remember in the very beginning when we had masks and we had the PPE available, you would take the N95 masks and they are appropriately to be stored in paper bags. And so everyone had a paper bag with their mask in. They put that together. So that was sort of a basis for how one might decide what are the lessons learned. And so how do I come to this? So you have to understand my perspective, because my perspective isn't your perspective. But I had three things going on at the same time in my role. I was dean of the College of Nursing. It was in New York City, as I mentioned, in the heart of the health corridor at the time, where you could see refrigerated trucks, you could see ambulances, you knew that all of the beds were turning COVID beds everywhere. But I also happened to be at the university, the chair of the Dean's Council. We have 20 deans at NYU, and we take our turn chairing that council as part of faculty governance. And usually the heavy work lifting is simply making sure that lunch is ordered once a month for when the deans get together. But I ended up in this role at the start of COVID. So I ended up in the largest global university, which has 16 global sites representing all the deans in all of those facilities to the president and to the core group that was now dealing with students in dormitories, not only here, but throughout the world. And I was also president of the American Academy of Nursing. So, which is the fellowship of the representing all nurses at a certain point of accomplishment. And I was a spokesperson for nursing along with the president of the American Nurses Association. So, and our focus at the American Academy of Nursing was health equity and health for all. That was our slogan. So if you look at this leadership, situation, you might decide to yourself, well, this is impossible. Maybe I can't, I'm dean of this nursing school. I certainly can't do all of these things at this time in New York City. Maybe I need to ask the the president-elect of the academy to step in at this time. Maybe I need to ask, I got to get rid. I can't do all three of these things. But I had to take a moment and say, well, actually, how can I do all three of these things and use them in a way that's synchronous and makes the whole more than the sum of the parts, which is what I did. And that ended up being the right thing to do. And people were like, well, how do you do all these things? Well, I had been a dean for a number of years. I had a very good team. I could turn a lot of the internal function of the school over to the deans internally and focus on the larger university. And then I could use the American Academy of Nursing position to highlight the work of nurses, which really gave me an advantage to do that. So that's the vantage point rather that I come to for these particular lessons. And so the lessons that I'll share with you today are from my perspective, and there's 6 of them. 1, we were not prepared, period. 2, overall, nurses and health providers gained. Now, we're hearing nothing now except we're burnt out and there's not enough of us. But overall, we did better and people are talking about us. So that's good. Equity gaps were exposed now on a grand scale. So we knew there were equity gaps. We've known it forever. But now they were exposed. It was like the veneer was ripped off and it became obvious. Aging persons and their care suffered significantly. The leadership that came through everywhere, whether it was leadership of a course or leadership of a unit or leadership of governments or leadership of enterprises or universities, sort of did okay. There were plus things and there were minus, but leadership stepped up sometime, but not always. And moral distress everywhere been exacerbated, which is not unusual in pandemics. That's the nature of what happened. So let's talk a little bit about we were not prepared. So here's an example of a little story I'll tell you of one of the things that happened in all these roles that I had. So I'm sure you've seen this picture of the USS Care. I might get that wrong, but this is the Navy hospital ship that arrived in New York Harbor, and everyone was cheering, and there were all these pictures. And meanwhile, there's not enough beds. Nursing homes are closed. You can't get into them. The place is a mess. But here comes this big ship full of ICU beds and ventilator equipment, and it was going to pull into New York Harbor and be there. The woman in this picture is a Rear Admiral Susan Ortega. Susan Ortega was the chief nursing officer in the U.S. Public Health Service when COVID-19 hit. So you probably don't even know about her, but she happened to be a colleague friend of mine, and we were both fellows in the American Academy of Nursing. And I knew her, and importantly, I had her cell number, and she had my cell number. And so I, in the middle of this, I'm like, I think I better just see, does she need some help? And so I contacted her, not knowing if she would be so busy, because she was on TV. She was like one of those people dressed in the suits that you would see with the Health and Human Services Administration team that's going to get together for this. And she got back to me and said, yes, I'll call you. I'm too busy right now, but I have some things that I might need help with. This is an example of we were not prepared. So when she called me the day or so later, she said, well, I'm in charge of setting up the bed hospitals in tents at the convention center in New York City. It's called the Jacob Javits Convention Center. You know, if you've been to New York, it's up, on the west side and not far from Midtown, not far from Times Square. And she was charging up, and she said, I have enough nurses to bring. But at that point, we were putting everyone with COVID on ventilators. And we didn't know if we had enough ventilators in the world to save everybody. We didn't know enough about, we were just starting to learn that if you put people prone, that they did better breathing and all of that. And she said, so I have nurses, and I've got equipment, but they don't know how to use ventilators. So they're med-surg nurses, but now they may need to do this. Do any of your faculty have some kind of module to quickly teach a med-surg nurse how to use a vent? And can you get that to me? And in New York City, it just takes a minute, and you always say yes. Yes, we can do that. Why? Because we have huge capacity in New York City. It's a big place. So I said, yes, we will do that. So I call or reach out to our faculty who lead our acute care NP program. And I said, the chief nursing officer in the U.S. Public Health Service is setting up beds. Can you, or do you have, or can you create a mobile app to teach med-surg nurses to use a vent? And they said, yes, we don't have it, but we've got something, we can move it to an app. And so we were able to get together with not only our instructional technologists at the nursing school and do all of this, and they turned that around in a week or so, or in 5-day business days, and they had it to her, which then she disseminated to the entire public health course. So that tells you, one, they should have been prepared for that to begin with. I mean, that's a basic, if you have a respiratory pandemic, you're going to need a lot of nurses prepared to understand how to use that equipment. We didn't, but we could bring this big ship in and park it in a port that we never put anybody on, because we didn't need those ICU beds. I think a couple of people went there, but we moved this big ship. But boy, that made, the government look good and made the governor of New York look good. And isn't all that's applaud, but we never used it. But what we did use was this mobile app. And she herself tells this story over and over again when she goes around now talking about that crisis, about how things like government agencies need to work with schools of nursing. We need to have that, because she didn't have anyone else to go to. She knew me. She had been to our school. She had visited our faculty because I invited her there. So that's how we did it. But that's not preparation. That's reaction. And when, I don't know whether any of you understood, or when you were involved in emergency management, about what are the acronyms that are used commonly in security, in crises, in the military, whatever. And this is something that popped into my mind, thankfully, as I realized I'm in this spot now to do all this leadership with the Dean's Council, and the deans were like, oh my God, what do we do? How do you form a crisis team? What do we do about all these students? And I was, the Dean's Council, and I sort of remember VUCA. And VUCA stands for volatility, uncertainty, complexity, and ambiguity. And that's exactly what this crisis was, all of those things. So how do you then address those issues when we were really in a state of volatility, uncertainty, complexity? So with volatility, you set up a vision. So for example, the vision I set up in the School of Nursing is that everyone's going to graduate on time. We will get everybody there. Nobody's going to be behind. We need this workforce, and they will have the best experiences, and we're not going to shorten that. We're going to get, and if we can get people out early, we'll get people out early. So that was a vision in my school, but you could have all kinds of other visions. The president of the university was like, all of my students in campuses and in dormitories are going to be safe, and we will not become a vector for disease in the university. So you establish this vision. Uncertainty, you create understanding. So this is what nurses do all the time. You have a patient is uncertain about their diagnosis and worried to death. You bring understanding. You do health education. You teach them about that. We could do that as nurses. We knew what to do. Complexity, when you have everything very complex, you remember, oh, is it caused by this? How is this going to spread? Where is it going? Who has it? Who doesn't have it? Do we test? Don't we test? Do we mask? Don't we mask? Blah, 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 all that complicated. This is a new kind of, these cells are going to do this. These cells are going to do that. You need clarity. And that's where some of that leadership was plus or minus, because not everybody was good at clarity. And explanation and communicating better, and everyone has admitted that that's been a problem. But the more clear I got, the better our nursing school did, the better the university did, the better the profession did. And ambiguity means you got to be agile, you got to have alacrity, you got to be able to adjust. What you're hearing 1 hour may not be what you have to do the next hour. It's going to change. You got to be agile, you got to be nimble, you got to be going, is that true? It's like, do this, don't do this, use this mask, put a trash bag on, take a trash bag off, all of that. It was, you got to be ready to change. And it doesn't mean that what you did before was wrong. It just means that the information is changing every minute. And that is what the students who experience this will know throughout the rest of your career, because you learned it in real time. And then there's this other BANI, which some people have been using, which really emphasizes when you're in these situations, how much to, use mindfulness, use intuition, really get inside yourselves to understand. And that, when I saw this one later, I realized that I was using that during that time. A lot of times I was just going with what some people might call gut, but it really is a conglomeration of all the things you've experienced before and how you're going to trust that and move ahead, because sometimes you just had to trust your experience. So we all also know, and Jen asked me to talk a little bit about policy. So what's the policy if we weren't prepared? We were short-sighted on supplies. Companies that made masks had stopped having the equipment to do that because it didn't make them any money. But nobody was assuring that they would always have the business and be supported in that business. It's like we support agriculture, that in this area. Farmers aren't growing for a year, they're still supported. But we were not doing that with businesses who create PPE. And we didn't have stockpiles at local levels where they needed. There's a lot of cheese stored around the country if we're all starving, but how do you get to that cheese? That there's like huge stockpiles of like plastic wrapped cheese in the United States. You get to know these things when you talk to these people. We had stopped supporting in education and in clinical practice and in research. We had stopped supporting population health and infectious disease prevention. And in some ways, we stopped thinking of it as important. As somebody who used to teach these classes and used to try and work this in to the community, it was like the rest of the faculty are like, I guess we have to teach that because there's questions on the NCLEX, but nobody really felt that it was necessary because we were now into chronic disease mode. We weren't going to have germs coming back and hitting us. That wasn't going to happen. So we had stopped doing that. And we had stopped thinking about that, and vaccines and things like that just became sort of normal or not something that we value, kind of put it in the back of our minds. And we weren't investing in community and home-based care. We've been tipping-toeing into that for aging for a long time, but we haven't made the turnover to where despite the fact that we all say we would rather live our long lives in what we consider our home or neighborhood and not going off somewhere, we still haven't, as a society, said that's where we want to be. Even though there are fledgling programs that are successful in the community for all-inclusive care, a hospital at home, and investing in primary care. And why do I bring this up? Because we had all these people in nursing homes who were suffering terribly, and we weren't prepared for the fact that people who were caring for people in nursing homes who got sick needed to go to the hospital. And then that was one of the negative decisions made in New York State, where the governor, they weren't thinking, and they said, oh, well, we can't take patients from nursing homes in the hospital. We don't have room. But yet then everyone infected everybody in the nursing homes, and that just spurred on. So we hadn't been thinking about this well enough. What would then an emergency look like? So lesson 2, we've gained. There's been attention to workforce shortages in my entire nursing career. But now there's a lot of attention. So that's why I'm saying gaining. So what's going on right now that you should be aware of? Well, I don't think you can open up any kind of social media or news anywhere where you don't see something about this right now. So right now in the Senate, there's a committee in the Senate called the U.S. Senate Health, Education, Labor, and Pension, and it's co-chaired by Senator Bernie Sanders and forgetting Cassidy's first name, John Cassidy, I think. But anyway, they're bipartisan committee, and they are sharpening what needs to happen in the Title VIII program. So what's the Title VIII program? That's the education program for health services administration. And that pays educational programs and schools, medicine, nursing, physical therapy, pharmacy, to support faculty salaries, to support, I had money when I went to school, stipends for people to go to school. So they are right now zeroing in on this. So you should write to these folks and say you support increases in Title VIII funding. And all of the nursing organizations right now are speaking the same conversation. If we want to do something about the workforce shortage now, we need to address more money in nurse corps, like have a public, well, there is a public health service nurse corps, but we need to invest in that. We need to talk about it more. We need to make it a practical thing for people to do. Loan forgiveness increases, growth of faculty, graduate medical education, which pays for residencies for physicians. Can we use that model? There's been an increase in support, more slots for, but how about for nursing? How about for physical therapy? How about respiratory therapy, which was in dire need? How can we do that? Really understand where we have the use of Medicaid, that we can use that funds perhaps, or for other funds to reinforce more preceptorships. I was just talking with the faculty this morning about this. How can we think differently about how preceptorships for all of our students are promoted? And learn lessons from what we know from healthy work environments, which are places where there is a magnet certification or a niche, that's nurses improving care for health system elders. So these programs ensure that there is a standardization and recognized through certification that a health system, a hospital or health system, has a healthy work environment for nurses. They're part of governance, they have something to say about it, people feel positive, there's quality measures. And that isn't shouted enough. We all talk about JCAHO recognition. There's JCAHO and magnet should be the two top things, because we know through more than 20 years of evidence that they make a difference in retention and of nurses and clinical outcomes. We were talking this morning with the faculty as well about career ladders and recognizing all who are involved in nursing in a way that contributes to the value of nursing. It's not just registered nurses, it's also certified nurse assistants, it's also LPNs, it's people who are supporting us, all of the people in this room who aren't registered nurses, but who are supporting nursing, are part of the nursing enterprise. And we need to help people think that through and think about careers in nursing. And of course, we still don't do interprofessional education as standard. And the more we can do that, the better. And I know that you had Sue Hassmiller speak here earlier this year, who led the Future of Nursing Report 2020 to 2030. And you can just look back at the kind of things we said in that Future of Nursing Report as important for how we can continue to do better out of COVID. And you can scan this on the slides. Isn't this cool? This is what IT people do. So this is an article in Scientific American. So one of the things that I did is, because my communications team at NYU was doing a lot of public affairs work, communication work with me. And we were talking, and she was saying, oh, it's so wonderful. All the people think nurses are so wonderful and they're hand holding and, they're the ones crying with the patients and all of this. And I'm like, yeah, but they're also trained as scientists. And if you become a nurse, you're spending a lot of time in prerequisite courses in science, and we're forgetting that. So she and I wrote a piece together for Scientific American. She said, I think I can sell this to Scientific American. So we had an essay in Scientific American saying that nurses are also scientists, to the point where a picture of a nurse gowned in an ICU with all of that. I said, that nurse is looking at that patient, that nurse is giving them care and empathy. Her hand is on the patient. What she's doing with that, she's feeling that they're sweaty. She's assessing if it's hot. She's looking at that. She's assessing, what is the patient, what's the patient breathing? And behind her are all those data coming into her about respiratory flow, about EKG, pulse rate, and all of that. And then she's changing the fluids based on all of that. She's doing that all at the same time. So that's what's in that article. And that's why I say it gave us an opportunity to visually showcase. And the guy who was the editor for this piece of Scientific American said, you know, we haven't done much on nursing in a long time. And you know, he hadn't done anything in like 40 years in nursing and Scientific American. 40 years. So, boom. That's why I say we gain. Lesson 3, equity gaps were exposed on a grand scale. And hopefully, I don't think we're going to lose it this time. We're going to stay with it because it's simply immoral not to. So these are all the things that you all know from your lessons in teaching is the social determinants of health contribute to poor care. The unequal treatment is in its, came out from the Institute of Medicine, showcasing this for the first time. It's celebrating its 20th anniversary. So this is a year to highlight those lessons and bring those in and what we've learned. So it's access to care, it's chronic conditions, problems with provider and system match. It's all the things we know now and highlighting not just with COVID, but in maternal morbidity and mortality among people of color versus white folks and how they, no matter what your economic is and your geographic location, there's still a big gap there. And I was encouraging the faculty I'm meeting this morning to look at the National Commission to Address Racism in Nursing, because there's many recommendations. If you have a paper to do, if you're a student, it's a good resource for you because I was on this commission and we came up with action items in the areas of education, practice, research, and policy. And it's an active body of work. And so in terms of this health equity gap and lessons learned in policy, we have the Future Advancement of Academic Nursing Act in Congress has been introduced now. This is another thing to support. So this is funds to support enrollment reduction, enrollment to retain faculty or nurses working in facilities. It addresses issues of curriculum, behavioral health. You can read this. Support nurse science. So it's a wide sweeping FAAN Act introduced by Lauren Underwood, who I'll show you in a minute. I already mentioned the US Senate Health Committee, and then the MOMS Act also introduced by a coalition of House of Representatives to address funds for moms through these particular agencies in government. And Don Berwick, so those of us who've been kicking around healthcare and healthcare policy for a long time know Don Berwick. Don Berwick was the one that said there should be no nosocomial infections ever in a hospital. And if a hospital develops those nosocomial infections, they shouldn't get paid. He was head of CMS at the time. He's written this piece in 2020 called The Moral Determinants of Health in the AMA newsletter. And he says in this, now think about this, when the fabric of communities upon which health depends is torn, and to some degree we're feeling that tear coming out of COVID, we've exposed a lot of things, the health equity gap is there, then the healers are called to mend it. And those healers, may be us, they may be others, they could be all sorts of people. And that there is a basic moral societal law that says it just shouldn't be. And so it's all of society that has to address this, not us. So here's some examples of nurses who are doing this work that you may or may not even know about, but you could look them up. So Lauren Underwood is in the blue dress. She's Representative Lauren Underwood from Illinois. She is a nurse. She decided in her nursing master's program at, I think she was at University of Michigan at the time. She's a Johns Hopkins undergrad, that she would run for Congress. So she did, and from her hometown in Illinois. And she is in her second term, and she is doing marvelous things. You can read about her and support her. In the center there, Sheila Burke in the white blouse and black has been is a nurse. She, in her 20s, became chief of staff, Senator Robert Dole. And she is highly regarded throughout the federal government, throughout the nation, as a nurse who walks both sides, bipartisan, of the committee. And when she calls someone, they answer. She is a highly valuable person who would love to hear from any nurse about what we're thinking and what we're doing. And here is your current Rear Admiral Alma Davis, who is now the Chief Nursing Officer for the U.S. Public Health Service Corps. I already mentioned Susan Ortega, who was the prior Chief Nursing Officer, who moved up into Assistant Surgeon General role. And Mary Wakefield. Mary Wakefield has been a nurse and active in government roles for many, many years. She is very highly regarded and respected. She was the interim secretary of the Department of Health and Human Services for a number of years before the last administration turned over. She's from North Dakota. She's a champion of rural health. She worked for Senator Tom Daschle for many years. And you may have heard that the Center for Disease Control was recently, they recently have assigned someone to take a look at why didn't the Center for Disease Control, why wasn't it one as prepared as it should be? Why did it have such a hard time getting out of its own way to do the work that it needed to do? Why was it stuck in bureaucracy, and why did they have such a communication problem? And so they appointed someone from the current executive branch administration to investigate and fix that. Who do you think it is? It's Mary Wakefield. And she is like undercover. She's not going to be in the press. She's not going to be, she is the in-charge person right now. So any changes that you see coming out of Center for Disease Control is going to come from the nurse. So these are the kind of things that are important for us to know in terms of where nursing is in this. Lesson 4, we know aged persons suffered more. So here's some of these very difficult times here. I've already mentioned Governor of New York, Andrew Cuomo's COVID-19 nursing home fiasco shows how not thinking about the ethical parameters of what you were doing when you said nursing home patients can't come into hospitals, or we can't invest in that, because he's thinking, or his team was thinking, well, we can't spread this way or that way. But then the unintended consequences is horrific problems. Washington State had a very difficult problem with nursing homes, long-term care, and hospitals. And if you recall, they became, like New York, one of the first places that became an epicenter for COVID, and just simply were not prepared, and still are struggling. I have a project that was funded by CMS to go in to do promotion of not only education, but interaction consultation to help nursing homes in Washington State get back. They're so underwater that we ended up stopping the project because they don't even have enough people that even would answer the phone and talk to us. They're still in such crisis mode. On the other hand, in long-term care, there was a committee through the National Academy of Medicine that used to be called the IOM, and they have this quality of nursing home report that came together just in the last, within the last year. And they have this report which you can scan. And in this photo are two people, Jasmine Travers. We need to get out of the room. Oh. Jasmine Travers, who is an assistant professor on my faculty of NYU, who's doing research in long-term care, gaps of care. Alice Bonner, who's the other woman there, is a nurse who's been working on over a use of pharmaceutical agencies and nursing homes for many, many decades. And so here's two nurses who are very active with this report, and they gave testimony to the select subcommittee on the coronavirus crisis just in the last 6 months. Lesson 5, we gave you a few examples of sort of plus minus. Here we have Dr. Ernest Grant, a nurse. If you don't know him, he was president of the American Nurses Association during COVID. So he was one of the voices in the media talking about the need to protect nurses, the need to protect groups, but also to have PPE, and that nurses should not be forced to care for patients if they're not safe themselves. And he also himself publicly campaigned for the need for vaccines and to overcoming vaccine hesitancy by being one of the first to publicly get a vaccine himself and talk about it. And he did a major campaign around that. And here I am on one of the opportunities I had to be calling for the most vulnerable groups who were going to be the most effective from the get-go. And the American Academy of Nursing, along with 4 other nursing groups, were able to meet with the senior White House staff at a time to hear nurses' opinions. And we all took a different angle. ANA took the angle about the most important thing is PPE. But the Academy of Nursing took the point that you're going to see this the worst, where there are crowded conditions, where people are living together closely in institutions where they are aged, where there's limited resources, prisons, boarding homes, things like that. That's where you need to go first, because if you don't go there first, it's just going to spread more. But these are going to be the people seeing the worst of the condition. Lesson 6, moral distress being exacerbated. We've known that nurses and other healthcare providers feel moral distress because of the nature of the work we do. And this is one of the lessons that we need to even more address this as a way to not only prepare students, but also to prepare ourselves. And in this article by Connie Ulrich in 2010, in the Journal of Advanced Nursing, this is 2010. So where do we see problems? Higher stress among younger and experienced nurses, staffing patterns, advanced practice, surrogate decision-making. We knew that in 2010. She, along with others, Morley and Grady, I'll mention Grady in a minute, 2020, COVID-19, what are the ethical challenges? Pretty much the same. And this is what they identified. Now, Christine Grady she's head of the NIH ethicist committee. She's a nurse ethicist. I've interviewed her and her husband as part of, you can Google this and find this, and her husband, Anthony Fauci. Anthony Fauci is married to Christine Grady, who's a nurse ethicist. So just, we're everywhere. This study was done at NYU, looking immediately at the frontline nurses who were caring for patients, finding that what did they say they were most helped by if they were feeling depression and anxiety. They were helped by the fact if they had support from, or if they were giving support to others. That made them feel better. Training in the PPE, reducing uncertainty, and if they had support from family and friends. So the more you can support family and friends, the better. And now we are asking, as this recognizing the need to address moral distress, behavioral health is a HHS coming out of the White House as a resource. More flexibility models, learning from other industries where your dry cleaning, your wash, your groceries, your transportation are taken care of. We hear stories of nurses getting into their cars, trying to drive home and crying and all of this. Well, shuttle service helps. All kinds of other industries do that, but in the hospital industry, the healthcare industry, it's like, oh yeah, those nurses are great. They'll work themselves to the bone, and then we need to speed up. No more bone. We're not doing that. Treat us better, and have different models. Healthcare work environments should have nurses engaged and with voices. So here's just the last couple of slides. You can scan this. Here's some very interesting emerging influences. Instead of all the funding from NIH driving toward cure or driving toward clinical trials, this new agency, ARPA-H, is based on another agency that used innovations to come together in new and different ways to solve a specific problem. And this is now just getting started. Myself and Nancy Rediker, who was head of the Council on Advancement of Nursing, were on advisory conversations and committees to get this started. All health professionals are part of this. And this, I think, will transition how we investigate problems from the way we have been doing into thinking about things differently. Another emerging influence is a report that came out this past October on the Lancet Commission. This commission, which has a nurse on it, first did a recommendation for health education in 2010. They wanted to do another one in 2020. COVID slowed them down. They just put it out. And the three things they're focusing on in higher education globally are education for life, competency-based education that includes these other climate, telehealth, ethics teams, and learning technologies. And what did you just do? You just walked me this morning through your clinical simulation center. And the more this is a way to really think about moving so much ahead. And in the education for life, they talk about three things that you have to understand that you're going to learn for life. What you learn today may not be true or relevant 6 months. So you have to constantly be on top. You have to have a way of making sure that you learn how you are going to be taking care of people. That's going to change. Home-based care, virtual, telehealth, all of that. And you have to learn how to take care of yourself. You have to have a lifelong plan for yourself for what makes you not only a better learner, but a better nurse to promote resilience. And we need to build that into our curriculum to help the students understand how they do that for life. And there's just some numbers. So around the world, we're investing a lot in medical and nursing education, but this needs to be upped. There's 110 billion in 2018. That was about almost a 50-50 split between nurses and doctors, maybe a little about 60-50, but that needs to be addressed. So society has to respond. You know, people say to me, how's the School of Nursing going to help with the workforce shortage? I said, I can't do anything more. I am doing everything I can. The structure is running on all cylinders. We're getting it going. Society has to decide how we're going to solve the shortage. It isn't just our problem, it's everybody's issue. And here's just some things to think about that we know. It's, you know, the controversy we have with here's money, but, you know, is it just going to go down the drain if I give it to a lot of build new buildings, or build new sim centers? Rural versus urban. You have the courage to innovate. Do we have teams that look like this around the table, sitting there and solving problems? But it's going to take all of us putting our hands on top of each other and working together. And that's what helped us through COVID. That's what we knew worked when we did it. And you hear the stories of units that came together differently, but felt so much a part of that. And that needs to continue. So I'll stop there. I think I have a few minutes. I don't know whether there's people trying to get into the building or into the room or not. 5 minutes for questions. So am I the only one seeing chat come up here? Because it's like, yes, thank you, David. But thoughts, does it make sense to you? Resonate? My husband's back there nodding, but I pay him to do that. So thoughts? I'll look to the faculty because now I feel like I know you. You can answer the question. No, you can't. You become. So when I say that we gained in our lessons as nurses, do you agree with that or disagree? You think we gained? Yeah. Yeah, all of our IT people and our technologists our educational technologists are telling us we had all this here. Nobody, and that's true all throughout higher ed. It's not true only in nursing. Yeah, and we took it. I mean, we responded, we saw it, and because we had all these things in place, we just kind of said, "This is a crisis. Leap through it." Well, the height was not the height, but in the summer. So the summer of 2020, what the state of New York Education Department was fabulous, and they worked with everyone to approve any changes we wanted to do. So what we did is we took all of the theoretical for the summer and fall and put it in the summer. And then in the fall of 2020, we did all those clinicals. So they might have been 2 days in OB and then 2 days of the week in med-surg. And that propelled that forward. And with the NP programs, the DNP master's programs, we had already reached the hours in that spring, so we just did it. And so that's how we did that. And we could count simulation. Must be getting hot outside. So that's what we do. We had a very good, but I think New York was recognizing that it wasn't going to have a workforce if it didn't do that. Gaining. Well, that hopefully, I mean, if we can't let them off the hook. Can't let anyone off the hook. Now it's like, we got your attention. Now this is how it's together. Society and us, you got to work together. We're just not going to do this working ourselves. Right. So the question was, if you couldn't hear it, the ideal model for taking care of our seniors and interprofessional work that comes together. So the ideal model is the program for all-inclusive care of elders, which started from the community that banded together in the 1970s in San Francisco, the Chinese American community who wanted to keep their family members home or nearby rather than have a nursing home level of care. And that model has grown now to a Medicare model. So you can look it up, PACE. NPA Online, I think is their website, programs for all-inclusive care of elders. And and we need to grow those, but that's the model. It's a Medicare, Medicaid funded model, and it could be Medicare private funded, and it's a community-based network model that people can remain in their home or their neighborhood, and it's an interprofessional care model. That's the answer. All right, well, thank you very much. Thank you. All right. So